So I'm on the plane today. I got here just 10 minutes ago. My ears are still in San Francisco. And I was listening to my favorite new artist, St. Vincent. How many of you have heard of St. Vincent? Check her out. And the refrain in this one song is, "I can't turn off what turns me on." And I thought, how appropriate is that for what I'm about to talk about? Because when you look at all of the problems we have in the health system, it's not just drug addiction that we can't turn off because it turns us on. If you have a system that's designed for everybody except the people it's serving, that's your health system. That's your cancer system. Why do I say that? Our medical record system's meant for billing. Our hospital practices are meant to make things easy for the doctor. The treatments are designed by trials in which they never consult with patients before or after the trial. If you go to dinner, you are surveyed by open table before dessert. If you're in a clinical trial that you have spent lots of money and a lot of precious time while you're in pain, you never get asked, how was your experience? What was your experience? When I worked at Pfizer many years ago, we started a program to do that, and it was the first one in the entire industry that asked the people in the clinical trials, how was it for them? So at the Biden Cancer Initiative, we're doing something embarrassing. When my mother says, "What do?" I say we're trying to create the cancer research and treatment system that you think we already have, right? You think if somebody knows how to treat a cancer in New York, they know how to treat it in Omaha. They don't. You think if your doctor finds something interesting about you, he or she shares it with everybody right away. They don't. You think you can get your medical records and contribute them to a research project. Good luck. You think that when we do a trial, we would ask the people we're going to be poking and torturing, what's meaningful as a result for them, for their family, for their lives, for their caregivers. We don't. Those are the things we have to do before we can get to the right system, which would be patient-designed, patient-focused, and much more humane than the system we have today. But there's a much bigger problem. You know, there's a lot of stigma for lung cancer patients. Probably the biggest group of cancer patients are lung cancer patients, and they suffer from stigma that they deserved it. We have pediatric cancers that suffer from a total lack of empathy because people don't want to spend the money to do the trials, to take an adult drug and try it in children. And now, and I'll not as a political statement, but just as an observation, there is a crisis of empathy in this country that is separating us from the people we're trying to help. It separates us from drug addicts we're trying to help and people who are stuck in the system. My own father in 2000 was addicted to opioids before it became fashionable. His pusher was his doctor. And after my sister and I got him off and put him on to things like Tylenol, his doctor put him back on. So when he got cancer, treating his pain became an incredible challenge. And yes, even in 2000, in Blytheville, Arkansas, friends came by and stole his drugs while we weren't looking. So it's a problem I'm very familiar with. But now I'm dealing with the fact that so many cancer patients need pain medication, and yet our system in this country is not designed to provide them with the information they need on how to manage it. In fact, when I had my own treatment for leukemia, and I'm in the industry, so to speak, everything that happened to me in the hospital was a complete and utter surprise. The moment I started my chemo, the nurse put protective gear on, but not on me. That was kind of weird. And then they said, you're going to be there 3 days. I was there 5 days. Nobody told me I had to stay until my electrolytes balanced. That took 5 days. The doctors would come in with residents and talk about me, but never talk to me, except to train a resident on how to interview a patient with a gown that doesn't close in the back. So all of these things combine to let me know that our system is completely divorced from the people we're trying to help. So how do we bring these communities together? So we did 3 things in the Cancer Moonshot, which I worked for Mr. Biden on in the White House in 2016. And we had 9 to 10 months to try to make a difference. So the first thing was, how could the government make a difference? How could private sector and academia make a difference? And how could individuals make a difference? So to boil this down very quickly, for the government people, I'd been in government before. I knew what to expect, and what to expect are programs and budgets. Not much empathy there. So I asked a different question because I think the starting question makes all the difference in the world. And my question was, where do each of you, 20 different agencies, from the National Endowment for the Arts to NASA, DOD, NCI, all the alphabets, where do you touch patients in their journey from prevention through detection, diagnosis, treatment, and survivorship? Where do you touch them? And if you've never thought about it that way, go back and ask the people you work with, where do we touch patients in their journey? How can we do that? Do it better, do it bigger, do it faster. And they came up with some amazing things, partnerships that they didn't expect, partnerships that we didn't expect. And then we asked the private sector, what are you doing? What are you doing to touch patients in their journey? A huge consulting firm came in to say, what could we do? I said, you represent millions of people who work for the clients you consult for. How many of them have cancer? Have you ever asked your clients how many of your employees have cancer? What are you doing to help them in that journey, especially the survivorship part, which nobody ever talks to them about? And what we ended up with, that particular group started an X Prize on prevention to try to bring attention to the beginning of the journey. And in fact, this happened over and over. So literally the second week I was on the job, the head of public health from George Washington University, whom I've known for years, came to see me and said, what can I do? I said, bring back an idea in 2 weeks from your digital team at the public health school. So in 2 weeks she came back and says, we have a whole program on social media treatment programs for tobacco addiction that we want to launch in Washington, which has a higher than average rate of smoking and lung cancer. I said, great. A week later, the head of the Case Western Cancer Center came to see me and unbidden said, we have a whole program on the science of addiction that we want to do in Cleveland, which has a high rate of smoking, in the housing projects where people never get tested for lung cancer and they have an incredibly high rate of lung cancer. So I said, why don't you talk to George Washington? And they put together a Washington-Cleveland program, which has now gone national, to go to at-risk populations for tobacco addiction and lung cancer screening. It wasn't our idea, it was their idea. They needed someone to encourage them and scale it. At the same time, we have people working in prevention programs of other sorts. HPV vaccine. This is one of those only in America kind of arguments. There is a higher rate of uptake of the HPV vaccine that deals with 98% of cervical cancers in Rwanda than there is in the United States. Why? Because the right wing thinks it's about sex. Well, it's not about sex, it's about cancer. But if we don't get the right message out, people in this country jump on the Puritan bandwagon that we inherited from our ancestors, and instead of saving their daughters and their sons from certain risk of cervical cancer, they say, no, if they have a vaccine, they'll feel free to have sex. This makes no sense at all, but it's the kind of thing we have to deal with. Now, the last thing about trying to help people understand our health system is they have to be in it. The best thing about Obamacare was that it said to the American public, we are all going to be in the same boat. Everybody's going to be insured. Why does that matter? Why does it matter my 25-year-old daughter is insured? The biggest determinant of who survives cancer is who has insurance. Period. Full stop. It's not complicated. If people are not in the system, you can't reach them, I can't reach them, they don't reach you. But people with insurance get tested and they get checked and they don't think they have to go broke to take medicines in most cases, although that's still a huge problem for many. But the point was, you can't have a health system where some people are in and some people are out and expect to have a public health program. And at the same time, when I say a lack of empathy, if you have a director of the Center for Disease Control who thinks it's okay to invest in tobacco after in office, what are we talking about? What are we talking about? This cannot keep going. We have got to bring people back into the system, give them hope. One last point. When I was diagnosed with my cancer, 2 of my friends were diagnosed with different cancers, multiple myeloma and glioblastoma. One of them died when I finished my treatment for leukemia, the woman with glioblastoma. One of them died a month ago after a 3-year fight with multiple myeloma. When people say to me, what can you get done in 9 months in the White House working on the cancer moonshot? I remind them that 9 months was half of the life of my friend with glioblastoma after her diagnosis, and a quarter of the life of my friend with multiple myeloma. 9 months isn't enough to finish anything but a baby, which is a pretty big deal, but it's plenty of time to get started on things that can change people's lives if you're willing to get started. And I know you are, and I thank you for it very much.